Welcome, and today we're talking about the vestibular system as it relates to postural function. Now, this is going to be a really great and interesting topic to dive into because literally when we talk about vestibular function, we are talking about the posture system. These two systems work directly with each other for upright postural design. Hi, I'm Dr. Krista Burns from the American Posture Institute, and today we're talking about vestibular function. So first of all, let's talk about postural neurology. What is postural neurology? What does that mean, and how can you guys utilize postural neurology into your practices? So postural neurology is a brain-based approach to controlling the posture system. So we do brain-based posture analyses and brain-based postural correction systems to then evaluate brain function in relation to biomechanic function of the posture system and how those two systems are working together. So again, we evaluate brain function in relation to the posture system, and then we understand which parts of the brain we need to either stimulate or defacilitate in order to have better proper posture. So when we do a brain-based posture analysis, what we're doing is we're evaluating the patient's level of neural capacity, their level of neural capacity on their initial visit, and then of course with their re-examinations as a follow-up to evaluate their improvement of neural capacity. With the brain-based postural correction, the purpose with the brain-based posture analysis is to determine the origin of distortion. With the brain-based postural correction system, what we're doing is we're stimulating those origins of distortion to improve function of the nervous system, to improve function of the brain specifically where that weakness was found during the analysis, to improve neural capacity and to improve upright postural design and while making neuroplastic changes in the brain. So that's postural neurology. Again, it's a brain-based approach to making neuroplastic changes in the posture system, and we can see changes of the posture system by evaluating neural capacity and by evaluating the posture system itself. So when we talk about brain-based postural correction, I want you guys to think of a system called eyes, spine, vestibular. So eyes, spine, and vestibular. Now, the reason that we focus on the eyes, spine, vestibular model of correction is this. So eyes represents the visual system. Now, when I talk about the visual system, I want you guys to think about orientation and head posture. So literally our visual system is how we orient ourselves within space. So for example, if I close my eyes, then I have less orientation within my environment. I'm not exactly sure where the things are around me, so I have less orientation. So the visual system is for orienting ourselves within our environment, and it's also, when it works in collaboration with the vestibular system for the VOR reflex, which we're going to talk a lot more about a little bit later, it's for head posture. So when the visual system and the vestibular system are working together in synchrony, we have proper head posture design. If there's visual inacuity or if there's a lack of VOR reflex, then we see head posture distortion patterns. So we're talking about the eye, spine, vestibular model of correction. Eyes, the visual system, represents orientation and head posture. And then when we talk about the spine, we're talking specifically about sensory motor integration. So sensory motor integration then is exactly as it sounds. It's an integration of the sensory afferent input and the motor descending output. So what happens with the sensory motor system and why we refer to the spine with sensory motor integration is this. The body receives afferent input. So for example, if I feel a stimulus on my right hand, that information travels up the spinal cord to the left sensory cortex. Now the left sensory cortex perceives this information, perceives this afferent input, and then it integrates with the motor cortex to make an appropriate response. So the response could be a withdrawal response if this was a hot sensation, or it could be to continue having the sensation applied if it's a nice and soothing application of the sensory stimulus. So based upon what kind of information is received from the stimulus in the sensory cortex, then a proper motor output response is created by the motor strip or by the motor homunculus within the frontal lobe. So that integration piece then happens within the brain, but the information travels through the spine. So the ascending information comes up to the contralateral part of the brain through the spine, and then it descends from the contralateral side down to the opposite arm. So again, I receive information on the right arm, it travels up my spine to the left sensory cortex. Integration occurs between the sensory and the motor cortex. That information travels from the left motor cortex down the spine to my right arm. So that's sensory motor integration. So when working with patients during brain-based postural correction, we want to integrate that information to the point that the better inputs that we put into the body, the more specific outputs that we get to the body. Now, when we talk about the vestibular system, so that's the third component of the eye spine vestibular model, we're talking specifically about postural balance and upright postural design. There's two functions there. So the vestibular system overall controls equilibrium and balance. So we have sensors within our inner ear, and we're going to talk more about this, that perceive any changes of body position in relation to gravity. And the job of the vestibular system then is to equalize, so bring us back central in an upright extended postural design to resist gravity, to keep us properly balanced upright against gravity, even in the form of unstable surfaces, or if there's a perturbation, for example. So if I get hit from behind and I'm not expecting it, I may sway forward, but my vestibular system kicks in to tell me that I'm swaying forward and will bring me back centralized, back to center, to restore that equilibrium of the posture system. So again, when we talk about the vestibular system today, recognize that it is the third component of the eye spine vestibular postural correction model for the brain-based approach. And again, the eyes are orientation and head posture, spine for sensory motor integration, and vestibular system for upright postural design with extension as well as equilibrium and postural balance. So we'll talk a lot more about that. Okay, so we talked about the importance of the vestibular system for posture, which is going to be extension and balance. So what do your patients commonly present with? If your patients are anything like my patients, which is the majority of society, what we're seeing a lot more of these days is flexor dominant posture. So a flexor dominant postural presentation looks like this. My head goes forward, my shoulders rotate forward, and I have chest drop, so my chest flexes forward anterior like this, and I'm in this position. So with this position, I'm not resisting gravity with the most amount of efficiency possible. What I'm doing is I have what's called a lazy posture. So I'm flexor dominant. My flexor system, such as my pecs, is dominating me forward here with gravity. Where I want to be is upright and extension. So with a nice extended posture, when the vestibular system is firing properly, what we see more of is we see patients without forward head posture. They're able to look forward directly in front of them. Their shoulders are pulled back, and they have nice postural stabilization of their spine, allowing them not to have the anterior chest flexion. So again, this is flexor dominant posture, and this is an upright extended postural design. So we see that difference in patterns when the patient's vestibular system is functioning properly or not. So it directly impacts the posture system. I want you guys to really understand that, because when you're working with patients, you can spot dysfunction of the brainstem, which is going to be the vestibular system, and the brainstem area called the PMRF the second the patient walks in the door if they have this flexor dominant posture. You can also see it very well on posture imaging. When you do that part of your brain-based posture analysis, from the posture image, you can understand if the patient has flexor dominant posture or if they have a proper extended postural design. Again, the majority of patients coming into your office, I'm going to tell you right now, are going to be flexor dominant patients, meaning that you do need to work with their vestibular system in order to get the best postural correction results possible. And when I talk about best results, I'm talking long-term results. I'm talking actually changing the brain by making neuroplastic changes of the posture system. That's going to be the best way to make those changes. So when we talk about head posture, so we're talking about in relation to postural design. So we have multiple different posture quadrants of the body. Let's talk about posture quadrant 1, which is the head and neck. So what we see with patients who have vestibular dysfunction of the posture quadrant 1, the head and neck area, is that they have a head tilt. So what we're going to see is they're going to have a head tilt toward the side of otolithic dysfunction. So within the inner ear, we have receptors called the otoliths, and the otoliths sense acceleration and deceleration and lateral head tilt in relation to gravity. So it's going to be the linear movements that the otoliths respond to. So when there's otolithic dysfunction, we see a head tilt in posture quadrant 1. That's going to be the very specific postural dysfunction or postural distortion pattern that's associated with vestibular dysfunction in posture quadrant 1. So again, head tilt toward the side of otolithic dysfunction. What we're going to see in relation to the rest of the posture system, most specifically posture quadrant 2, is going to be a postural hyperkyphosis. So I was just showing what flexor dominant posture looked like. In addition to that, in addition to my shoulders rolled forward and anterior chest flexion, if you were to see my spinal presentation, it would be a C-shaped curve. So this C-shaped curve is what's called a postural hyperkyphosis. So if I have an inability of stimulating extension to resist flexion, then I have that C-shaped curvature, which is a postural distortion pattern referred to as postural hyperkyphosis. I want to make a distinction here because a postural hyperkyphosis is not the same thing as a structural hyperkyphosis. With a structural hyperkyphosis, the patient actually has a structural deformity of their spine, which is creating it to curve forward into that C-shaped spinal presentation. However, with a postural hyperkyphosis, the difference there is that the patient does not have a structural deformity. They do, when prompted, have the ability to stand upright and to extend their postural system. However, they don't have the postural fitness, or they have vestibular dysfunction or PMRF dysfunction that's preventing them from being able to resist gravity in a non-flexor dominant position for a long period of time. Now, these are the patients that you're going to get the best results with, because when you understand the physiology of the vestibular system, how to stimulate extension, these patients are going to develop postural fitness to resist gravity in an upright extended posture and not present with that C-shaped spinal curvature or a postural hyperkyphosis. Okay, so I have some slides up behind us here you guys can see with the internal ear. Let's talk a little bit about the anatomy and the physiology of the vestibular system so that you guys can understand what I'm talking about in relation to the neurophysiology. So we have the internal ear here, and within this aspect here of the inner ear, we have the 3 semicircular canals and we have the otoliths. So you can see those there on the picture. Now there's 3 semicircular canals and 2 otoliths per ear. So on the left side, for example, we have 3 semicircular canals. We have the anterior, the posterior, and the horizontal. And then we have 2 otoliths, which are the utricle and the saccule. So overall, we're going to have 5 on each side in terms of sensory organs, sensory receptors for the vestibular system. Now, the sensory input comes in from the outer ear. It comes into the inner ear. It's perceived by the otoliths if it's acceleration or deceleration, or if there's a tilt versus normal gravity. So if there's a tilt that takes us out of typical verticality, which is straight up and down. So that's going to stimulate the otoliths. Now, if there's a rotation, for example, if I'm rotating my body to the side, or if I feel like my body is spinning, these patients are going to present with vertigo and they have dysfunction, then that's going to be stimulation of the semicircular canals. Okay, so again, we have the semicircular canals, the anterior, posterior, horizontal canals, and then we have the otoliths, which are the saccule and the utricle, and they respond to acceleration, deceleration, changes in tilt, and changes in verticality against gravity. Now, this information is then taken from the sensory receptors of the inner ear, and that information is transmitted along cranial nerve 8, which is the vestibulocochlear nerve. So the vestibulocochlear nerve has a couple of branches. That's a long name, right? Vestibulocochlear. Now, the vestibular aspect of the vestibulocochlear nerve is what we're talking about today when we're talking about vestibular function in relation to the posture system, versus the cochlear nerve of the vestibulocochlear nerve is going to refer to auditory information. So that information is going to ascend to the brain for perception of auditory input. This is how we hear and how we perceive that information. But we're talking very specifically about the vestibular aspect, the vestibular nerve, as it relates to postural balance and equilibrium. So then the vestibulocochlear nerve carries the information from the inner ear to the vestibular nuclei, which are located in the brainstem. So within the brainstem, let's see. So within the brainstem, you can see it here. The brainstem has the mesencephalon on top, the pons, and then the medulla. So it's created with 3 parts. Now, there's actually 4 different vestibular nuclei. The 4 vestibular nuclei are going to be located in the pons and the medulla. So the information, again, comes from the inner ear. It projects along the vestibular nerve to the brainstem, specifically the pons and the medulla aspects of the brainstem, and that's where those vestibular nuclei are located. Now, from that point, we have ascending pathways and we have descending pathways. So the ascending vestibular pathway then is going to go from the brainstem up to the parietal lobe. So this is ascending information, meaning that it goes, from the periphery, which is going to be the external information received, up to the sensory cortex for perception. So what's important to understand about the parietal lobe, which is located right about here, you can see it is located in red on this model. So the parietal lobe, then, the function of this lobe of the brain is for sensory orientation. So we have the sensory homunculus, which perceives our world. So I was talking earlier about perception, okay, as part of sensory motor integration, but also the parietal lobe helps us understand where our body is in space, proprioceptive feedback, proprioception. So ascending vestibular pathways then ascend to the parietal lobe to tell our brain where our body is in space. That's going to be the ascending vestibular pathways. And then we also have the descending vestibular pathways. Now this is of utmost importance to postural design and postural neurology. So I mentioned here that this is the brainstem. This is the mesencephalon, the pons, and the medulla. The vestibular nuclei are located right here in the pons and here in the medulla. There's 4 of them, 4 vestibular nuclei. Now we have 2 different descending vestibular pathways. So the first descending vestibular pathway is called the medial vestibulospinal tract. Now the medial vestibulospinal tract is going to descend to the cervical spine. So it descends from the brainstem down to the cervical spine to coordinate movements of the eyes and the cervical spine. So I talked about, and we're going to talk about more, the VOR reflex. This is the vestibuloocular reflex, vestibuloocular, vestibular system, visual system, and that reflex of being able to keep our eyes focused on a target while moving our head in space. So that gaze stabilization aspect is going to be coordinated by a couple of different pathways, one of which is the medial vestibulospinal tract, okay? So again, there's multiple, but the most important descending vestibular pathways are going to be the medial and the lateral vestibulospinal tract. One descends directly to the cervical spine. The other, the lateral vestibulospinal tract, descends to the intrinsic musculature of the spinal column, so most specifically of posture quadrant 2 or the thoracic spine. So this pathway is going to stimulate extension. So I told you guys before that the receptors in my inner ear are going to perceive when my body changes position in relation to gravity. So if I'm tilted or if I'm turning, for example, if I have a rotation, that's going to stimulate my descending vestibular pathways to bring me upright into extension. Or for example, if your patient's sitting on a posture cushion or an exercise ball and they start to slouch, this is going to stimulate their vestibular system to bring them upright into a centralized position, upright against gravity. Okay, that's going to be the vestibulospinal pathway that stimulates upright extension of the posture system. So how cool is that? Literally, the vestibular system is so important and valuable to our posture system. So again, one of the descending pathways goes to the cervical spine to coordinate head movements with eye movements. And then we have another descending vestibular pathway that goes to the spine, to the spinal musculature to stimulate extension of the posture system to keep the body upright against gravity in relation to the ground, in relation to that gravitational force, okay? So those are the ascending and descending vestibular pathways. Now I talked about a minute ago about the postural distortion patterns. Here's some pictures for you guys to look at. So with the lateral head tilt then, again, I'm going to tell you that it's going to be towards the side of otolithic dysfunction. So in this image here, you can see that I have a right head tilt. It's very exaggerated in the photo. The right head tilt then is going to demonstrate right otolithic dysfunction of the vestibular system. And then over here is another exaggerated photo of flexor dominant posture, or that postural hyperkyphosis presentation. So you can see that I have that C-shaped curvature of the spine in this photo, and I also have anterior rolling of the shoulders and anterior chest flexion. So with this flexor dominant position, or this postural hyperkyphosis, then we know that there is lack of extension of the vestibular system. Okay, so lack of extension ipsilateral to the side of vestibular dysfunction, and lateral head tilt ipsilateral to the side of otolithic dysfunction. So now let's talk about some brain-based posture analyses, because what I've just done is I've presented you guys with a lot of information. Now this information is only valuable to you as a practitioner if you can actually apply it to your patients in your practice. Am I right? So let's talk about some different analyses that you can do, and then we'll talk about some correction strategies, because I want you guys to be able to use this information right away in clinic. So first we'll talk about some brain-based posture analyses. Now the first thing that I want you guys to do is pay attention to the case history. So the case history is going to tell you some important information about the function of the vestibular system. So for example, you're going to ask the patient if they experience dizziness, if they have any signs of vertigo, or if they experience motion sickness. Now some patients are just going to provide you this information. It may be the driving factor bringing them into your office, and then it's going to be an indication, a red flag indicate, not a red flag to refer out, but an indication to you that the patient has vestibular dysfunction. So again, if they have dizziness, if they present with vertigo, and if they present with motion sickness. So that's going to be an instant indication based upon their case history that the patient does have vestibular dysfunction. Of course, we're going to do further analyses to confirm our assumptions at this point, but those are good indications from the case history. So the first examination that you're going to do is called one leg balance. And how the patient performs this is you're going to have them stand on one leg like you can see in the photos here. I can also perform it just like this. So I'm standing on one leg. I'm bringing my leg up to 90 degrees in the same plane as my hip here. And what you want to see is that the patient can stand on one leg with proper postural design for 30 seconds or more. More is better. If they're unable to stand on one leg in proper posture for 30 seconds, then what you're going to watch for is the side of initial postural sway. Now this will be more evident in some patients than others, so you have to be watching. So for example, you have the patient stand on one leg, and some patients will have no sway at the beginning, and then after a few seconds you'll see them sway to one side, maybe then they'll sway to the other side. Always watch for the side of initial postural sway, because watch the difference here. If I sway to the right and then sway to the left, even if it's a larger sway to the left, that was a compensatory sway. My initial sway was to the right side with a compensation, a compensatory postural sway to the left side. So always watch for the side of initial postural sway because the patient is going to sway towards their side of vestibular dysfunction. So again, the patient will sway towards the side of vestibular dysfunction. Now, if the patient has good balance, you'll get these patients in your office, then have them close their eyes, because once they close their eyes, they're eliminating that visual field of gaze, and it'll be more difficult for them to stand on one leg with proper posture. So this will give you a faster indication which side they're going to lateralize to for their vestibular dysfunction, okay? So you can see that in both of the images there. Now again, you're checking for initial postural sway. Also, you're checking for postural changes. So if the patient's not swaying a lot necessarily, but you do see that they're starting to get uncomfortable in this position, and maybe they start going into a head tilt, or they start compensating with their posture, then these are going to be indications of a positive test that the patient has vestibular dysfunction. So if you don't see sway at that point, have them close their eyes and then watch which side that they have their initial sway to. Okay, and then the next test that we're going to do is the vestibuloocular reflex. So again, the vestibular system, the ocular system, which is the visual system, and that reflexogenic system for gaze stabilization. Now this is a really important thing because when the patient does not have proper VOR function, this can actually create a lot of anxiety for patients. This can be a source of motion sickness. It can lead to vertigo. So these patients, when they have vestibuloocular reflex dysfunction, not only will they have postural changes in their posture system, but they are going to experience symptoms as the case presentation advances. These patients can be highly symptomatic and highly compromised, okay? So what you're going to do is you can grab a pen, you can use your finger, if you have a pointer in your office, all that's good. So what you're going to do, I'm going to stand to the side so that you can see me, but recognize that you would be straight on with the patient. So what you're going to do is you're going to hold your finger in front of the patient's nose, midline to their face, and you're going to instruct them that they're going to keep their eyes focused right here on the tip of your finger. Gaze stabilization. They're going to keep their eyes focused there while rapidly moving their head in different directions. So as I do this straight on, then I'm keeping my finger out here. I'm keeping my eyes, gaze stabilized on the finger while moving my head quickly to the right. Okay, so this is not a slow, smooth pursuit type of movement like this. That would be the difference. It's not a slow movement. It's going to be a quick movement. Okay, if the patient has dysfunction of the VOR, the vestibuloocular reflex, what are you going to see? You're going to see multiple different things. Specifically, you're going to see that the patient is going to saccade their eyes, or they may even have a nystagmus. So what's a saccade? A saccade means that I lost my gaze stabilization, so my eyes went over here, but I know mentally I was instructed to keep my eyes focused here. So you'll see my eyes go to the right and then saccade quickly back to the left. So you'll see a quick movement of the eye back to center because the eye is then trying to regain that gaze stabilization back midline at the tip of the finger or the tip of the pen, whatever you're utilizing. Okay, so you're going to see a quick saccade. You might see a nystagmus develop. You might see that the patient feels uncomfortable. So, for example, you might see a headache. You might see that they have blepharospasm of their eyes. You might see postural changes. Maybe the patient is unable to keep their gaze focused. So what they're doing is they're rotating their head, or maybe they have a head tilt while moving their head to the right. You might see these postural changes because the patient's trying to compensate with their posture system for the fact that they have a decreased function of that vestibular system, or the VOR, the vestibuloocular reflex, okay? So those are going to be the things that you're going to check for. Now, I do want to mention that you need to check each semicircular canal. So again, there's 3 semicircular canals on each side. We have the horizontal canals, we have the anterior canals, and we have the posterior canals. Now, this gets a little bit tricky, so recognize you may need to watch this a couple of times to really get it down. Don't even worry, everybody needs to. Literally, it's kind of a difficult concept to grasp, so just work with me here. You guys can always come back and refer to this if you need it. Also, I'm going to post in the Postural Neurology Facebook group this week. I'm going to post a great guide for you guys that has pictures of everything that I'm talking about and some instructions, so you can refer back to that. So if you're a little bit confused the first time you hear this, no problem. You can refer to the guide or rewatch the video. So essentially, with the horizontal canals, how do you test VOR of the horizontal canals? Just like I was doing. So if my nose goes to the right, okay, I'm testing the right horizontal canal. If my nose goes to the left, I'm testing the left horizontal canal. Now, how do we test the anterior and the posterior? So each canal is 45-degree angle to one another. So what that means is that there's a paired system of canals. I want you guys to think of LARP and RALP. Now, what does that mean? So LARP is left anterior canal and right posterior. That's going to be connected. That's going to be the paired canals. LARP, left anterior, right posterior. Those are paired. And then we have RALP, which is right anterior, left posterior. Again, RALP, right anterior, left posterior. So that means that I can test these semicircular canals together. So if I'm saying left anterior, right posterior, or right anterior, left posterior, how do we check that? So if my nose goes to the left and then I go backwards, I'm checking the left posterior canal. But from this same position, okay, with my nose left, and I go forward, I'm checking the right anterior canal. Okay, let's go through that one more time. So my nose goes left to a 45-degree angle. As I go back, left posterior. As I go forward, right anterior. The opposite will be true as well. Okay, so again, I'm going to post photos of that in the Facebook group for you guys to refer back to, so you're really specific when you're in clinic. You can do it nice and fast to know which semicircular canal you're actually testing. Okay, so you want to test each canal individually, and again, you're looking for the same thing. So even if I'm testing the left posterior canal, I'm keeping my eyes focused forward on the same image here, or the same point. Okay, moving it quickly back to see if I can keep my gaze stabilized in a centralized, okay? So from that point, so we just did one leg balance and we did VOR testing. So those are a couple of different tests that are going to help you localize the area of dysfunction within the vestibular system. And then that provides us really important information of then what we can do for postural correction care. So let's talk about some brain-based postural correction systems of the vestibular system that you can utilize with your patients. So the first one is going to be called the balance progressions. Now, I want to tell you guys that we're at the American Posture Institute, we're a huge advocate that every patient should be doing balance, and they should be doing balance progressions, especially if your patient presents with vestibular dysfunction, okay? So literally, we have our patients, every patient working on balance because it's so valuable and so important to the development of their vestibular system, which directly impacts and affects their upright posture postural design. Does that make sense? Now, with that being said, not all patients are created equal in terms of postural balance. We recognize that some patients are highly compromised and they have a low level of balance ability. Some of our geriatric patients, for example, need to start at a lower progression, whereas even some of the kids, for example, whereas an elite athlete who has great balance is going to start at a higher lung progression versus a regression. Regardless of where each patient in your office is among the balance progressions, start them at that point until they can then perform that exercise and then progress them forward, okay? So we tested them with one leg balance so we know which side of vestibular dysfunction that they have. We do recommend that the patient does one leg balance on both legs for a therapy, because we do want to develop the vestibular system on both sides from this perspective. So how does the progression sequence work? First of all, we want our patients to be able to stand on one leg for 30 seconds while maintaining proper posture. Let's talk about proper posture, because what we don't want is that our patients think that they're doing rehabilitation and they're, balancing all over the place, just like this. They're moving all around. That's going to be an ineffective approach to their vestibular rehabilitation. What we want, if they have an inability of maintaining proper posture, is they're going to start with their hand against the wall. So I don't have a wall here, but it would be just like this. I would stand on one leg with my hand stabilized against the wall. As I start to feel more comfortable, then I can start, barely letting my hand off the wall for a couple of seconds, putting it back on, letting it off, putting it back on, letting it off, putting it back on, to the point where I feel stable enough to take my hand off for a few seconds at a time, leading up to 30 seconds. So proper posture during this exercise then is going to be that the chin is pulled back, the ear is in alignment over the shoulder, the shoulders are pulled back so I don't have this flexor dominant shoulder anteriority and chest flexion. So I have my shoulders pulled back in upright extended posture. I have contraction of my core musculature. I can bring my leg up to 90 degrees, okay, with my knee in alignment with my hip and my knee centered over my ankle, and both feet are going to be pointed forward and I'm able to look forward, okay? So that's going to be considered proper posture. So again, if the patient can't do it without stabilizing, they start with their hand against the wall for 30 seconds. As they can then progress forward, they just do one leg balance with their hands by their side. From that point, if they can do that without problems, they're going to do one leg balance with their eyes closed. So it'll look like just in the photo that you guys saw earlier, I'm doing one leg balance and then I close my eyes. Okay, it's going to make it that much more difficult because I'm eliminating my visual field of gaze, so that's considered a progression. And then from that point, with the eyes open, have the patient do one leg balance on an unstable surface. So for example, an unstable surface in your office could be foam, it could be a Bosu ball, it could be a posture cushion. Also at home, for at-home rehabilitation, this is a really good thing that you guys can tell your patients, is they can just take like a beach towel, for example, and just fold it up and then stand on that beach towel. So they fold it up into fourths, for example, and they're going to stand on it, and it creates that unstable surface that the patient can then do their balance training on. And then from there, you do one leg balance on an unstable surface with their eyes closed. That would be the next progression. And then doing one leg balance on whole body vibration and one leg balance on whole body vibration with the eyes closed, okay? So those are going to be the balance progressions that you can utilize with your patients, and I highly, highly recommend that you do. Literally, we're working on postural balance with every patient because regardless of what point in the progression system they are when they come in on their first visit, we need to keep developing their postural fitness when it comes to postural balance. Okay, so those are the balance progressions. And then the next thing that the patient needs to work on is going to be VOR training. So you went through and you tested each of their semicircular canals with the VOR training. So if you found, for example, that the right horizontal canal, that you saw a saccade of the eyes or you saw a nystagmus, then that's going to indicate that the right horizontal canal is in fact dysfunctional, and we want to build that neuroplasticity of that system. So what we're going to do then is we're going to do the exact same test that we just did, then becomes the therapy, or it becomes the advanced vestibular training that the patient will do at home and in your office, okay? So again, if I had right horizontal canal dysfunction, then what I'm going to do is I'm going to, at home, for example, or even at my desk, while working, I'm going to hold my finger up, and I'm going to do this 5 times to start off with, going to the right while keeping my eyes gaze stabilized central. Now, if the patient's compromised, start with 5 repetitions. As they can do 5 repetitions, advance them to 10 repetitions. And then you can start making it more fun, a little bit more difficult. You can have certain things hanging on your wall that they utilize for their VOR training, such as we have those targets, for example, a shooting target. So instead of just looking at their finger all the time or looking at a pen tip, they can look at certain parts of the target and then move their head to the right in this case example. Also, you can have them do this, the VOR training, while doing one leg balance, for example. That would be considered a final progression. That would be a progression towards the end of their treatment plan or as they develop more neuroplasticity. Also, you can have them do VOR training on whole body vibration, or you can apply handheld vibration to certain parts of the body while doing VOR training. So all of those things are going to be progression. So based upon your patient's level, of neuroplasticity when they start off with, they may just start by doing 5 repetitions, or they may start by doing 10 repetitions, and they're going to progress forward to doing one leg balance with VOR, or doing whole body vibration with VOR, or handheld vibration with VOR training, okay? So keep stimulating the patient. While they're doing their rehabilitation, we want to bring them to the point of neural capacity, of neural fatigue. So bring the patient to the point of neural fatigue, just to that point where they're about to have postural breakdown, not beyond it, because we don't want the patient to actually break down in the office, but you want to bring them to the point where they're challenging their system. That's the only way to create neuroplastic changes, okay? So start the patient off where they need to start. And then the next part of the brain-based postural correction series for vestibular training is going to be extension exercises. So extension exercises, a lot of your patients are going to be doing extension exercises. If they're seeking out postural correction care, it's very likely that they have this flexor dominant posture presentation. Now, if they have flexor dominance, then we want to bring them into upright extended postural design. So one of the best exercises that you can have your patients do in office and at home is going to be a Superman exercise. So you can see in this picture that I'm doing it on an exercise ball. The patient can also do it on the floor. They don't even need any equipment to do this. It's very, very minimal equipment required. But what they're going to do is they're going to bring the body back up into extension and hold that position. So they're going to hold the extension for 10 seconds and perform this for 5 repetitions. Now, again, as the patient's able to do this, have them hold it longer and do more repetitions. Keep advancing them forward to bring them to the point of neural fatigue during their brain-based postural rehabilitation. That's how we're going to create those neuroplastic changes that we want in order to get the long-term postural correction results that other practitioners just aren't getting, because they're not bringing their patients, they're not recognizing that neural capacity component to then create neuroplasticity. So extension exercises, Superman, great exercise the patient can do in office or at home. Also, if you have your patients lying on a table while waiting for you to come in and do their manipulation or do their treatment, then as they're lying face down, you can have them doing Supermans in your office before even doing the treatment plan. So for example, the patient is instructed to lay down on the table number 2, for example. So they're laying there waiting for you, and as they're doing that, you can instruct them or have your assistant instruct them to be doing Superman exercises to stimulate the vestibular system, to stimulate extension before having their treatment applied, okay? So that's going to prime the vestibular system, it's going to stimulate extension, and then you're going to come in and do, your treatment plan for that day for that patient. So that's a way that the patient can get that done even before the treatment is applied while laying down waiting. So we want to keep them engaged while in the office. Another thing too, in the office, going back to one leg balance, if the patient is standing around waiting, maybe they're waiting to check out, schedule their next appointment, instruct them when they're standing in the office to be doing one leg balance, okay? So they're doing one leg balance while waiting to check out at the counter. While waiting for you to come in the room, if they're laying face down, they're going into a Superman position. So you want to encourage the patient to maximize their time spent in your office so that they can get the most maximal benefit from their experience in your office and get the best postural correction results out there, okay? All right, so that's going to conclude our brain-based postural correction exercises. So again, we went through one leg balance, we went through VOR training, we went through the balance progressions, okay? We went through VOR training and we went through extension exercises, Superman being a great extension exercise. I promise you guys, if you start checking for vestibular dysfunction, you're gonna find some interesting findings, and then by applying these treatment protocols with your patients, you're gonna get great results in terms of vestibular correction, which is going to directly impact upright postural design. Again, we talked about that when we talk about the eye spine vestibular model of postural correction within postural neurology, then that vestibular component is for better balance and equilibrium and upright postural extension. So utilizing these exercises is going to be so important for your patients to get those long-term neuroplastic changes of the posture system. So if you guys are interested in learning more about postural neurology, about how it can help your patients, about how you can implement it into your office, what to look for in specific case presentations, and of course, how to make neuroplastic changes to the posture system with your patients, then I encourage all of you to join our Facebook group. So we have a Facebook group called Postural Neurology that's set up with that direct intention, with the intention of providing you high value so that you can then, you can put this stuff to use. Because again, this information is only valuable to you, the professional, if you're able to utilize it in practice. So we keep everything very clinical, very evidence-based in terms of our treatment protocols within the Postural Neurology Facebook group. So I encourage you to join our community, join the Facebook group completely for free. I'm constantly posting in there, updated videos, updated research studies to help you guys have that evidence-based approach for postural neurology within your practice. So I hope you guys enjoyed this information regarding the vestibular system. I promise if you apply it with your patients, you're going to see great changes with the posture system. And again, I encourage you to join our Facebook group. I'll see you there.